So I'm going to give you a small update of what has happened in the world of carcinoma esophagus in the next 10 to 12 minutes. And surprisingly, this has been a year in which we got some surgical development. I have a surgical bias when I'm doing this presentation, unfortunately, or fortunately, a little bit of bias. So the aim has been to do the things we do better or minimize or the treatment which you're offering. So it's been a good year for us. So I've split it into multiple sections. So there are elements in diagnosis and staging where we have improved, in rehabilitation where we have more evidence, in neoadjuvant therapy, and in the surgical approach as well, which is unusual that such a lot of surgical trials come out in 1 year. So we all know that the preferred modality for staging of esophageal cancer is PET-CT. It's there in the NCCN guidelines, regardless of stage, PET-CT is recommended. That's an 18 FDG PET. But the AJCC 8th edition includes Sievert's 1, 2 as esophageal cancer. So G-junctional tumors, which are Sievert's or signet cell, are included with esophagus. Can we use the same FDG PET? Unfortunately, for stomach, it's not recommended. So we are in a, somewhere in the threshold whether to use it or not use it. So is there anything better? There has been some promising evidence that a FAPI PET, that's a gallium FAPI PET, is better than FDG PET in signet cell carcinomas. So this is a preliminary data, 25 patients only. They picked up 5 more patients out of 17, and they found that a higher SUV uptake, even in the primary and even the sites of MET. So this is promising. We in TMH, also in the biomedical department, imaging department, has started off a study in which they're using FAPI for signet ring carcinomas, and they found very encouraging results. So this is something we should keep track of, because signet ring and Sievert's 2 and 3 is a confusing area where we really don't know which modality to use for staging. What about prehabilitation? All surgeons know that prehabilitation is absolutely important for the patient's well-being. And this year we have got some pilot studies, randomized studies, which have come out, which show that a 15-week program, which includes exercise regimens and psychological coaching, including, in addition to nutritional support, improves QOL and improves completion of neoadjuvant therapy. So it's important for all modalities. So if you think these are soft endpoints, there is other studies also which have gone on to show that prehabilitation improves recovery after MIS esophagectomy. And harder endpoints like length of hospital stay, ICU readmissions, all were reduced with prehabilitation. So it's become an important part of the armamentarium. This goes along with the ERAS. So ERAS, the esophagus protocol, came out in 2019. And this year we got even more encouraging results showing that, it has solid endpoints which are much better. Like the hospital stay has been reduced from around 11 days to 7 days. The cost is better, and earlier bowel movement. And it's applicable across the board to all patients of all age groups. So ERAS definitely should be part of your protocol when you're going for radical treatment for esophageal cancer. So that's a big jump. Now comes the elephant in the room, which we've been discussing for the past couple of hours. What are the neoadjuvant options available? And you're aware, Cross, Neocritic, MAGIC, and the FLOT. I saw the results of the previous debate. Unfortunately, these slides were made much before. And what we do in Tata Memorial is, for squamous cell carcinomas, we prefer giving neoadjuvant chemoradiation, and for adenocarcinoma, it's perioperative chemotherapy. So what data has come out in the last 1 year is we got the long-term results of both the Cross and the Neocritic trial. And they've shown the same advantage with neoadjuvant chemoradiation persists, more so in squamous cell carcinoma. And in the Neocritic, which included only squamous cell carcinomas, there's a 10% benefit favoring NACT-RT. So that's a solid advantage. But as we saw in the debate earlier, there are many unresolved areas in neoadjuvant chemoradiation. We know the guys who have pathological complete response really do very, very well. So what about the guys who don't get pathological complete response? They do obviously worse. Can we do anything more? That's a question we need to answer. What about, can we avoid surgery if we detect pathological complete response? Again, an unanswered question, whether we need surgery at all. And obviously the eternal debate, peri-op was, Anishil was debating about this one. So for this one, we got one answer. This is the Checkmate trial which came out about adjuvant nivolumab. In patients with residual disease, non-PCR, after surgery and neoadjuvant chemoradiation, there is a definite benefit in terms of disease-free survival, almost a doubling with nivolumab. So this is very encouraging data because it is useful across all subgroups, regardless of histology, location, PD-L1 expression. So immunotherapy definitely helps in this group. It's really encouraging. It's a poor prognosis group. But unfortunately, like Kumar said, only 3% of our patients can afford immunotherapy. So how useful it's going to be in real life is yet to be seen. That's about the addition. Now, surgery. So esophageal surgery has been, going on for 100 years, but we still debate the same stuff, whether to do transhiatal, whether minimally invasive. Now, the thoracic approach is still often debated. In the panel discussion earlier, Dr. Mistry asked the question, Ivor Lewis versus neck, robotic versus VATS, what extent lymphadenectomy. Fortunately, we got 3 trials answering all these questions in the last 2 years. About the approach, this is the ICANN trial, which compared a McEwan's 3-stage with a cervical anastomosis with an Ivor Lewis. And not unsurprisingly, they found that intrathoracic anastomosis, that the Ivor Lewis was associated with lesser leaks at 12.7%. That's almost 1/3 as compared to a neck anastomosis, and lesser major complications, 11%. Obviously, the recurrent laryngeal nerve palsy rate also was much better. So wherever possible, keeping oncological principles in mind, that is an adequate margin, 3 centimeters with a lymphadenectomy, probably an Ivor Lewis surgery gives you better short-term outcomes than a McEwan's 3-stage with a cervical anastomosis. So it's a very interesting trial. What about minimally invasive? VATS has a proven benefit in 2 randomized trials, so there's no debating VATS. Now the question is whether robotic is as good or better. It would seem, looking at the trends, that robotic is becoming more popular. So there was a randomized trial comparing with open, definite benefit. Now the comparison is with VATS, the RAMI trial. It showed a shorter operative time, higher lymph node rate. They obviously didn't look at long-term outcomes, but comparable outcomes were short-term outcomes between the 2 arms with considerably more expense. So it's showing good outcomes as compared to VATS, but again, in the real world, how effective it's going to be, unless it shows superiority, is still up to debate. This is the biggest elephant in the room. This has been debated often and often. Fortunately, this has come out. There's a large randomized trial from China, 400 patients. Unfortunately, they didn't give neoadjuvant therapy. They saw 21.5% unforeseen cervical metastasis in the 3-field arm, but it didn't translate to an OS or DFS benefit with a 3-field. So again, there's no benefit to 3-field is what this trial shows. But there are a couple of issues with this trial. One is the lack of neoadjuvant therapy. So I don't know how relevant it is today in 2022, where 93% of patients who in Tata Memorial actually get neoadjuvant therapy of some sort. So the relevance is gone. They unfortunately compared a total mediastinal lymph node dissection with a 3-field, not with a 2-field. So we really don't have an answer as to whether 3-field is better than 2-field or an infracarinal lymph node dissection, which is what we consider as standard. So that question is yet to be answered. Probably the TMH trial will be the only trial which compares a 2-field versus a 3-field. So we'll have to wait for the data on that one. So what we know at the end of this year is that we have better evidence for prehabilitation in ERAS. Without that, I don't think you should be taking up any patient for esophageal surgery or multimodality treatment. We know that the patients who receive neoadjuvant chemotherapy or chemoradiation, the PCR patients do very well. Now we know that neoadjuvant chemoradiation, non-PCR, adding nivolumab improves disease-free survival with the usual caveats. We also know, it's off-debated topic, that we have better short-term outcomes with an Ivor Lewis approach as compared to a McEwan's with a neck anastomosis. But we have to pick the right patient. Not every patient is suitable for an Ivor Lewis. Oncological principles have to be maintained because this trial did not look at long-term outcomes. There is limited evidence supporting the use of robotic esophagectomy, showing that it is equivalent to VATS, but the cost considerations have not been addressed in this study. And a 3-field lymphadenectomy is non-superior to a total lymphadenectomy. So the question of 2-field versus 3-field is yet to be addressed. So what do we have to look forward to? There are many questions. We are trying to minimize treatment in many sections. So do we need neoadjuvant RT at all, as mentioned in the cross protocol, which we debated? So there is a next trial going in Japan where they look at DCF versus CTRT, NACTRT. That will be really interesting to show that in squamous cell carcinoma also, do you need neoadjuvant chemoradiation or just NACT with 3 drugs, is it good enough? So the next trial, and there is a CMISG trial. So in squamous cell carcinoma, also they are looking at whether radiation is required in the neoadjuvant part. In the neoadjuvant treatment of adenocarcinoma, the debated topic, whether we need NACTRT or just neoadjuvant chemotherapy. So the neo-AGIS and the ESOPEC, the neo-AGIS preliminary results are out, but the final publication is not out. So these 2 trials will probably answer the question. Now the major question for important question for surgeons. Can we do surveillance after giving neoadjuvant chemoradiation, knowing that 49% of patients as per cross have pathological complete response? Is surgery at all? We're looking at ways to minimize treatment. There are 2 trials which are looking at surveillance. One is a SANO and the second is a NEEDS. These results will be really crucially important to us, especially in a country like India, where a lot of patients are lost to follow-up after starting neoadjuvant chemoradiation. So those 2 trials. Another important question which has been debated is the extent of resection for CEVER-2. So Dr. Mistry asked a question in his panel whether you would do an Ivor-Lewis or do a Garlock approach with a resection anastomosis, or you could do even a trans-hiatal or 3-field. This is a Dutch cardiac trial which is answering only this way. Only inclusion criteria is CEVER-2. Perfectly meant to answer this question, and probably we'll get the results in the next 2 years. And finally, we look forward to the TMH trial, the 2-field versus 3-field, which will probably tell us whether there's an advantage in doing 3-field. Thank you very much.